So if we look at the next case, so that was a case of immediate implant placement and immediate restoration. In contrast, this is a case where I would never consider an immediate implant. There are so many things happening with this case, and clearly there is a high aesthetic demand for the patient, a high lip line, and a thin tissue phenotype, which is even thinner over the canine itself, and in fact it lacks keratinized tissue. The soft tissue is missing. There's recession of about 6 millimeters or so, and the CBCT also demonstrate a missing facial bone. So everything you can think of that is going wrong or that can work against you in terms of aesthetic outcomes is happening in this particular case here. But this is where the early placement approach really comes into its own, because we allow biology to work for us to allow us to achieve a satisfactory result. The CBCT itself, of course, shows that there is ample bone dimension to place the implant once the tooth is removed. All we have to do is deal with the missing soft tissue and the missing bone on the facial aspect. So the recommendation for this case, therefore, was a type 2C approach: early implant placement and conventional loading. Early implant placement to allow spontaneous healing of the soft tissues. And here I usually recommend a slightly longer period of time post-extraction to allow more soft tissues. In fact, it almost becomes like a type 3, because sometimes it can be up to 12 weeks or so. And depending upon how the soft tissue heals, and of course I do monitor this over time. But here we are adopting an early placement with a slightly extended early placement time frame and conventional loading. So these are the clinical images post-extraction. So you can see from a facial view and an occlusal view. And this is now 9 weeks after extraction, both of the same views. Now the thing to see, of course, is if we draw a line between the central incisor and the canine, the gingival margins, you can see quite clearly that there has been a change in the position of the gingiva, if you like, or the gingival margin. There's been both a thickening and as well as a coronal increase in soft tissue volume. But of course, when you look from the occlusal point of view, there's been a flattening of the ridge at the same time. Okay, so you get that flattening of the ridge, but you get the thickening of the soft tissue and an increase in the height of the tissue. So these are the opposing factors that are happening. But we have enough to work with now when I place the implant because of that increase in soft tissue volume. And no grafting was done, soft tissue grafting was done to repair this. This is simply allowing healing to take place and allowing Mother Nature to take over and to allow things to heal biologically. So now we have the surgical opening, and typically the defect that can be seen here, but sufficient orofacial width of bone to allow the implant to be placed in the correct position. So the implant is placed, the typical GBR procedure. Any part of the implant that's exposed is grafted with autogenous bone chips, and here's the DBBM material that's then grafted over the top, and a double membrane technique is used to stabilize the biomaterials and to provide that barrier function. And because the soft tissues had rebounded vertically, minimal coronal advancement of the flap is required. The periosteum is released just to allow the flap to be advanced to accommodate the increased dimensions of the biomaterials, but you don't have to do a lot of coronal repositioning to get the flap closed. So here's the outcome 2 years later. You'll see from a facial point of view, a very satisfactory outcome. From an occlusal point of view, which is the second image on the left, there is that flattening. And those of you who are familiar with replacing maxillary canines know it is very, very difficult to reconstruct the canine eminence on the root surface. It's very difficult to do that. But in this case, despite that flattening, a good aesthetic outcome was achieved. The radiographic control, and on the right-hand side, the CBCT scan at 2 years showing that a facial bone of almost 2 millimeters in thickness has been reconstructed, and good thickness of soft tissues overlying that and into that crestal region as well. So once again, I'm very confident that a case like this will have minimal risk of soft tissue recession over a period of time. And you can see from a facial view, the facial photograph, that left canine really sits beautifully in harmony now with the upper anterior teeth. Of course, the big blemish is the right canine, which is the other tooth that was transplanted from the palate. And at some point in time, when that one undergoes resorption, we'll replace the tooth at that stage. But at this time, patient's happy to retain it the way it is. So this is an example of an early implant placement approach to take advantage of the soft tissue healing and the ability then to reconstruct the missing facial bone with the GBR procedure for contour augmentation. A really good example and showing a very satisfactory outcome.